Hello, everyone, and welcome to our module on dermatomes and reflexes. Let's start by talking about spinal nerve roots. So, spinal nerve roots are bundles of motor and sensory nerves that exit the vertebral column together. The only exception to this is C1, the first spinal nerve root. It contains only motor fibers, but all the other spinal nerve roots are a mixture of motor and sensory nerve fibers. And in the video on the spinal cord, I talk about the structure of the spinal cord, but in that video, I explain how the dorsal root of the spinal cord sends out sensory nerve fibers, and the ventral root sends out motor nerve fibers. And so these fibers bundle together and form a single root, a bundle of nerves that's exiting the vertebral column from a specific location. We divide all the spinal nerve roots up into a couple of regions. So there are 8 nerve roots in the cervical region, which is up near the head and neck, 12 roots near the thoracic region, 5 by the lumbar region, and 4 by the sacral region. And finally, there's one sort of funky nerve called the coccygeal nerve, which exits down near the lowest part of the vertebral column. And the nerve roots are named for the vertebrae near which they exit the vertebral column. So, for example, the C1 vertebrae has the C1 nerve root exit right above it. That's the case for all the vertebrae down until C7, which has the C7 nerve root exit above it. And then this is just sort of a quirk, but we only have 7 cervical vertebrae, but we have 8 cervical nerve roots. And the reason for this is because after C7 exits above the C7 vertebrae, you then have C8 exit above T1, and then we go down into the thoracic vertebrae. And so this is how the nerve roots are named. So now that we understand that, we can talk about what we mean by the term dermatome. So a dermatome is an area of skin. That's why it has the word derm in the name. And it contains sensory fibers that innervate the skin, all coming from a single nerve root. So for example, if you look at this image on the slide here, you can see this yellow region right here. This is the C5 dermatome. So that whole region has its sensory information going to fibers that are from the C5 nerve root. And so you can see in this image on the slide here, we have all these different dermatomes, these skin regions of our body, which have sensory innervation from a particular nerve root. So for example, C2 provides sensory information to the skin at the posterior half of the skull. That's the region for its dermatome. S2, S3, and S4 provide sensory information to the penis and anal region. And then all these other spinal nerve roots in the middle provide sensory information to other dermatomes as shown in the picture. Okay, so now that we understand that, we can talk about some key spinal nerve roots that are worth being familiar with. And we'll start by talking about C3 to C5. These nerve roots give rise to nerve fibers that go on to form the phrenic nerve, which innervates the diaphragm. Some people use the mnemonic C3 to C5 keeps the diaphragm alive. Now, these are cervical nerve roots, so they also provide sensory information to the shoulder. And so for this reason, when there's irritation of the diaphragm, sometimes patients will sense that as if it's pain in the shoulder. This is called referred pain. Classic example is gallbladder disease. So the gallbladder sits under the diaphragm, and if it becomes inflamed and irritates the diaphragm, sometimes patients will present with referred pain to the shoulder. They don't actually have a problem in their shoulder. The problem is in the gallbladder, but it's irritating the diaphragm and giving the sensation of shoulder pain. This can also happen with lower lung masses. They can irritate the diaphragm and cause referred pain to the shoulder. Anytime the phrenic nerve is irritated, this can cause dyspnea and hiccups. Basically, the hiccups are spasms of the diaphragm, and dyspnea can come from problems contracting the diaphragm to breathe normally. And if for any reason the phrenic nerve gets cut, this sometimes happens during thoracic surgery, the diaphragm on the side where the nerve is cut will become elevated, and this will lead to problems contracting the diaphragm and inflating the lungs, so patients can develop dyspnea. Another nerve root that's good to be familiar with is T10. This provides sensory information to the skin around the umbilicus, and this is where patients can sense referred pain from appendicitis. So in early appendicitis, when the appendix is inflamed in the abdomen, it will irritate the visceral pleura surrounding the appendix. That pleura is innervated by sensory fibers from T10, just like the umbilicus. So some patients early in the course of appendicitis can have pain that is referred to the umbilicus. As the inflammation goes on, eventually the appendicitis will bother the somatic nerve fibers in that region, and then the pain will migrate over to where the appendix actually is in the lower right quadrant. But initially, the pain can be in the umbilicus. Okay, next let's talk about another tie-in with spinal nerve roots and dermatomes, and that involves the infection herpes zoster, which is also called shingles. So this infection is a reactivation of a latent varicella zoster virus infection. So when you're first exposed to varicella zoster virus, that leads to chickenpox, which presents with symptoms like fever, sore throat, and a vesicular rash. But after the chickenpox resolves, The varicella-zoster virus can lie dormant in the dorsal root ganglia of spinal nerve roots, and later it can reactivate, and that leads to shingles. Shingles causes a rash which will be confined to a single dermatome. Usually it does not cross the midline. It looks like what's shown in this picture here. It involves the skin of a single dermatome on one side of the body. It can't cross to the other side because that's a different nerve root on the other side of the body. So this is common in patients who are elderly or immunocompromised. They can have reactivation of the varicella-zoster virus, and that can lead to shingles. And there is now a vaccine to prevent this from happening. And here's a picture of the rash of herpes zoster or shingles. You can see that it's on half of this man's body, and it's confined to a region of skin around one of the dermatomes of his chest. And I talk about this infection in a lot more detail in videos in the infectious disease section. Okay, so now let's move ahead and talk about reflexes. And to understand reflex arcs, let's talk about the patellar reflex, which hopefully you're familiar with. This involves taking a reflex hammer and tapping the patellar tendon just below the patellar bone at the knee. And when you do this, the patient will kick their foot up like this because the quadriceps muscle in the thigh contracts. So why does this happen? Why does tapping the patellar tendon lead to the foot sticking upwards from contraction of the quadriceps? Well, to understand this, let's break down the whole reflex arc into a series of steps. So first, you have a stimulus for the reflex, and that's when you tap the patellar tendon with the reflex hammer. This leads to an afferent signal. Afferent means arriving to the central nervous system. So it's a signal, a sensory signal that is coming into the spinal cord to the dorsal root ganglion of the spinal cord. And in the case of the patellar reflex, this will be at the L3 to L4 spinal level. That's where you find those sensory nerves that send out fibers to the knee. And so this is shown in this image. When you tap with the hammer, you're going to stretch receptors here, and these blue fibers are going to come into the dorsal root ganglion right here. And what they're going to do is immediately signal motor neurons over here at the ventral root of the spinal cord. And those motor neurons send fibers out to the quadriceps muscle. And that's going to cause the quadriceps to contract. And this is what's going to make the foot come out in this direction. And the idea here is that the degree of contraction of the quadriceps muscle is always maintained to keep your knee in a particular position. So when you tap the tendon with the hammer, the body thinks that you're trying to move the knee, and it tries to balance that by contracting the quadriceps muscle, and that's why you get the foot kicking out in this direction. And so the sensory fibers come into the L3, L4 spinal level, and for the quadriceps to contract, you need the femoral nerve to work. The femoral nerve is supplied by L2 to L4 spinal roots. So basically, if this reflex is intact, it means that everything from L2 to L4 is intact. And so that's how we refer to the patellar tendon reflex. We say that it tests spinal nerve function in the L2 to L4 level. And so besides the patellar reflex that we just talked about, there are a number of other clinically tested reflexes, and I've summarized the important details about each reflex on this slide. So to test the biceps reflex, you tap on the biceps tendon on the arm. This tests spinal cord levels C5 and C6. It sends signals out via the musculocutaneous nerve to cause the biceps to contract after you tap the tendon. That's the normal response. You test the triceps reflex by tapping on the triceps tendon. It tests C6 to C7 and then sends signals out by the radial nerve to make the triceps contract. We've already talked about the patellar reflex. You can test the ankle reflex by tapping on the Achilles tendon. It tests S1 to S2 and sends signals out through the tibial nerve to cause the gastrocnemius and soleus to contract and make the foot move. And then finally, two reflexes that we don't test commonly but that you should be familiar with are listed at the bottom of this table. So to test the cremasteric reflex, you stroke the inner thigh of a male, and this should cause the testicle on the same size to rise up by contraction of the cremaster muscle. This tests spinal nerve roots L1 to L2. They send signals out by the genitofemoral nerve to the cremaster muscle. And then to test the anal wink reflex, what you do is you stroke the skin around the anus, and you should see contraction of the external anal sphincter via the pudendal nerve. This tests spinal nerve roots S2 to S4. This is sometimes done in the trauma bay when you suspect the patient may have severe spinal cord injury. Another reflex you should be familiar with is called the jaw jerk reflex. To elicit this reflex, what you do is tap the chin while the patient's mouth is slightly open, similar to what's shown in this picture on the slide here. And then you observe for contraction of the masseter muscle, which will cause the jaw to jerk upward slightly. This reflex tests the trigeminal nerve, cranial nerve 5. The sensory fibers of this reflex arc and the motor fibers are all through the V3 branch of the trigeminal nerve, the mandibular division of the trigeminal nerve, which I discuss in other videos. This will activate the masseter and the temporalis muscles, and that's what causes the jaw to jerk upwards. Now, normally in a healthy person, this reflex is either absent or minimal. The key thing about this reflex is that it becomes brisk or hyperreflexive in patients who have an upper motor neuron injury to the trigeminal nerve. The upper motor neurons to the trigeminal nerve come through the corticobulbar tract, and you have to have bilateral upper motor neuron damage in order to get a brisk or hyperreflective jaw jerk reflex. So I talk about the trigeminal nerve in detail in another video, but for our purposes here, what you want to know is that when you tap on the chin, if you see a brisk or hyperreflexive response of the jaw jerking upward, that means the patient has bilateral upper motor neuron lesions involving the corticobulbar tract. Okay, next let's talk about the plantar reflex, which is a reflex you can test to determine whether or not the patient has a Babinski sign, which is evidence of an upper motor neuron lesion, usually a lesion involving the corticospinal tract. So to test the plantar reflex, what you do is firmly stroke the bottom of the foot. This is shown here in this image. You can either use your thumb or the bottom of a reflex hammer, and you stroke the foot usually upwards and outwards like this. The normal response, if the patient doesn't have an upper motor neuron lesion, is for plantar flexion of the big toe to occur. In other words, for the big toe to flex downward, the opposite of what's shown in this picture. It should come down in this direction. That's the normal response. It's abnormal if the toe does what's shown in this picture and it flexes upward. That's dorsiflexion. That's evidence of upper motor neuron damage because upper motor neurons usually suppress this reflex. And so when the big toe goes upwards like this, we say the patient has a positive Babinski sign, and that means that they have evidence of an upper motor neuron lesion, usually a lesion of the spinal cord involving the corticospinal tract. There is, however, one exception to this rule about upper motor neuron lesions, and that is in infants less than 12 months of age. They always have an abnormal plantar reflex with evidence of a Babinski sign. We'll talk about this in a minute, but this is because they have incomplete myelination of this reflex arc, and so therefore, in an infant, a baby under 12 months of age, you will always see an upward deflection of the big toe, and you will always see a Babinski sign. Clinically, we describe reflexes using a grading scale that goes from 0 to 4 plus. So when we say a reflex like the patellar reflex being tested here is 0, we mean there is no response to testing the reflex arc. 1 is a diminished response. This is what you see in lower motor neuron lesions, which I discuss in another video. 2 is normal. 3 plus is brisk, which means there's an upper motor neuron lesion. And then 4 plus means sustained clonus. This is also something you can get with an upper motor neuron lesion. Clonus means the muscle, in this case, the quadriceps muscle, if we're talking about the patellar reflex, it will contract and relax and then contract again. Basically, there's so much tension that the reflexive action of contracting the muscle is causing the reflex to occur over and over and over again. You can think of clonus as similar to a hyperreflexive or brisk response to testing a reflex arc. Okay, let's talk briefly about nerve root syndromes. So many of us, especially as we age, have degenerative changes or breakdown of the joints in our vertebrae. And what can happen is the nucleus pulposus, which is spongy tissue found between the vertebral discs, can herniate or stick out to the side. And this can cause compression of one of those nerve roots we talked about before, like C1 or L2 or S1 or what have you. So for example, if this happens in the neck, you can have a herniated disc compress C5. This is called a C5 radiculopathy, means a nerve root syndrome. And it's going to lead to dysfunction of all the nerve fibers that are involved in C5. So you can get pain and sensory loss over the shoulder because those nerve fibers are part of C5. You can also have weakness of shoulder abduction and loss of the biceps reflex, and that's also because of abnormalities of C5, which you need for these things to remain intact. So there are a lot of different nerve root syndromes, but the two that are most important to be familiar with are shown in this slide. So the first one is an L5 nerve root syndrome. This happens when you have herniation of the disc between L4 and L5. You can actually see this in this image on the slide here. So these are the intervertebral discs, and this one right here you can see is leaking out the side and pressing on nerve fibers in the spinal cord. When this happens, you're going to get back pain radiating down the lateral side of the patient's leg, on whatever side has the nerve root that's impinged upon. The foot strength will be reduced, but you will have normal reflexes in the lower extremity, including the ankle reflex. So this is the most common nerve root syndrome and definitely one you want to be familiar with. The second most common nerve root syndrome is at S1. When this happens, patients complain of pain down the back of the leg, not the side of the leg like you get with L5. There will be weakness of plantar flexion and the ankle reflex will be lost. So this is the second most common nerve root syndrome and another one you want to be familiar with. The lumbar region of the spine, where you have L5 and S1, has a lot of stress on it, and therefore this is where you most commonly see herniated discs and breakdown of the vertebrae. Okay, I'm going to finish this video by talking about primitive reflexes. These are reflexes that are always present at birth in normal newborn babies, but they disappear within the first year of life or sooner as babies age. And when you do your pediatrics rotation, if you get to round in the newborn nursery, you will look for all these primitive reflexes. And the reason is because babies who don't have these may have some form of central nervous system pathology. Also, if these reflexes persist beyond a year, that can also indicate some kind of developmental pathology involving the central nervous system. The idea behind these reflexes and why they're present at birth but they go away by a year of life is that they're inhibited by a mature frontal lobe. The frontal lobe has to develop and the axons have to become myelinated in the corticospinal and corticobulbar tracts, and this takes about a year to occur. So when babies are first born, their frontal lobe is not mature and they will have all these reflexes, but by the first year of life, the frontal lobe should be mature and therefore these reflexes should go away. They can, however, reappear later in life if patients have a stroke or some other pathology that disrupts the frontal lobe. And there are 6 key reflexes. They're all listed here, and we'll go through these in the next couple of slides. Okay, the first primitive reflex we'll discuss is called the Neuro reflex, also known as the startle reflex. To elicit this reflex, what you do is you lie the baby on its back, just like what's shown in this picture here, and then you lift the baby very slightly off its back, and then you let it go and let it fall down on the table, usually with some cushioning present, like what's shown here. Or sometimes you can catch the baby if you're holding it higher. This should elicit the startle reflex, which has 3 phases. First, the baby will spread its arms, then it will unspread its arms, and then the baby will start to get upset and cry. Sort of cruel, but this is a primitive reflex that indicates normal function of the central nervous system. And if you ever get to see this on a newborn baby, it's actually pretty fascinating how all the newborn babies always do the same things. They spread their arms, unspread their arms, and then they begin to cry when you do this. After 1 year of age, if you take a baby and try to do this, they will not have this response shown here. And then the other 5 primitive reflexes are listed on this slide. The rooting reflex involves stroking the cheek. The baby should turn toward the side of the stroke. The sucking reflex means that anything you stick inside the roof of the mouth, the baby will suck on. You can do this with a pacifier or a finger. The palmar reflex involves stroking the baby's palm, and it will collapse its fingers and grasp your finger as you stroke it. The plantar reflex we already talked about. That involves eliciting the Babinski reflex. You should see the Babinski response or the Babinski sign. That's normal up to 1 year of age, as we already said. And then finally, to elicit the glant reflex, what you have to do is stroke the skin along the baby's back, and the baby will swing its legs to that side. So usually what you do is you hold the baby up with one arm, and then you stroke its back, and it's pretty cool if you ever get to see this. The baby will literally swing its legs to the side of its back that you are stroking. That's the glant reflex. Normal and newborn babies should go away by 1 year of life. And that concludes our video on dermatomes and reflexes.